Welcome to PALS. It's Professor Young's Anatomy Lecture Series. In this place, our goal is to make anatomy simple. So if you're just joining us, you just stumbled into our video, you've not subscribed, I would really encourage you to please subscribe and be a part of this amazing anatomy family, where our simple duty is to make anatomy simple. This is actually part 2 of our series of lecture on the gross anatomy of the arm. If you've not seen the part 1, in part 1 we considered all the muscles that are in the anterior compartment. So in this section, I'll be discussing the muscles of the posterior compartment. I'll also look at some of the associated clinical correlates around this area. So what are we waiting for? Let's go to class. At the end of this lecture, I will expect all of you to be able to tell me the innervation, the origin, insertion and actions of the muscle of the posterior compartment of the arm. We'll also consider the artery of the arm, which is the brachial artery. We'll look at the extent of this artery, consider some of its relations, its branches. Finally, we'll look at the anatomical basis for the associated clinical correlates. So let's go to class. Alright, the posterior compartment is also called the extensor compartment. I'm sure by this time you will know why. Because the muscle in this compartment is involved in the action of extension. What's this muscle? The triceps brachii, the triceps muscle. And quickly I will tell you the nerve of this compartment. That nerve is the radial nerve. So let's take a look at this picture. Here is the region posterior compartment, and all these muscles will form just one muscle complex, the triceps muscle. So this is the triceps brachii. From the name, we'll know that this muscle has 3 origins. And what are those origins? There is a long head, there is a lateral head, and there is a medial head. So let's look at them. Here is the long head. And here is the lateral head. And then here, looking a little deep, is the medial head. So let's pick them again. Long head here, lateral head here, and then the medial head here. So if you look at the bony components where they're picking origin from, we're seeing this part of the glenoid fossa, the infraglenoid tubercle, and then we're seeing the point of origin of the long head, the lateral head. There's a groove in between the long head and the medial head. The name of that groove is the spiral groove. So that means above the groove, we're seeing the lateral head. Below the groove, we're seeing the medial head. So quickly, what are the origins of this head? The long head of triceps brachii will pick origin from the infraglenoid tubercle here. If you remember, the other tubercle we mentioned, we called it the supraglenoid tubercle. It is supraglenoid because it was seen above the glenoid fossa. And here, and it was for the long head of biceps brachii. We're also seeing the infraglenoid tubercle below the glenoid fossa. And this tubercle is for another long head, but this time the long head of triceps. So these 2 long heads are fond of these tubercles. Long head for biceps brachii, supraglenoid tubercle, long head of triceps, infraglenoid tubercle. So the other 2 heads, we already know where they're coming from the posterior aspect of the humerus, and then we have this groove, as I earlier showed us here. So the lateral head will be coming from above the groove on this posterior surface of the shaft of humerus, and then the medial head will be coming from point of the posterior surface of the humerus below the spiral groove. Alright, let's move on. Insertion. Insertion is also on the ulna. Which muscle did we say inserted on the ulna in the anterior compartment? Do you still remember? Oh, brachialis. So can we pick it out again here? Yes, it was here that brachialis inserted, and we said it's a coronal process. But we're not talking about brachialis now. We are talking about the triceps brachii. So the triceps brachii will also insert on the ulna. But the part of the ulna we're looking at now is the olecranon process of the ulna. And here is the olecranon process of the ulna. And by the time it fits into the humerus, a cavity in the humerus called olecranon fossa, this point will be seen at the posterior aspect. So this is that olecranon process of ulna when the distal part of the humerus is fitted into it. So this is the point of insertion of the triceps brachii. Nerve supply, as we noted earlier, is the radial nerve, and here is the radial nerve. So where is radial nerve coming from? Radial nerve is actually the biggest branch, the deepest branch of the brachial plexus. Which cord of brachial plexus? The posterior cord. We have done a very extensive discussion on the brachial plexus. The video is there in our channel. I also expect you to go and pick them up and then get comfortable with all these branches coming from brachial plexus. So back to our lecture, here is the radial nerve coming posteriorly and then running to the triceps. The action is extension, and then it extends the elbow joint. We will look at a very important vessel in the arm, and the name of that vessel is the brachial artery. Let's have a look. So here is the brachial artery. The artery we are seeing here running from this point, I will tell you the name very soon, to this other point. Of course, we know here is the elbow joint. So this artery actually is a distal continuation of the axillary artery. So as soon as this artery here, above here, I'm sure somebody still remembers which region this place is, the axilla. The axilla. So this artery, when it is seen here, it is called axillary artery. This muscle is called the teres major muscle. Where is it coming from? It's coming from the back of the scapula. Above it is another muscle that's called the teres minor. But that is not our focus today. Our focus is tracing the artery, the brachial artery. So where does this brachial artery begin from? We can see from this lower part of teres major and runs all the way down to the elbow joint. We'll look at that point of the forearm. But before that, let's look at how it ran. It actually ran between two muscles. What are those two muscles? Biceps brachii superficially and brachialis deep. So it will be running between these two muscles. That is actually hidden by these two muscles. And remember, we said it is the artery of the anterior compartment of the arm. So how does it supply the posterior compartment? We'll be talking about one of its big branches that will be going to the back to supply the posterior compartment of the arm. For the termination, it is at the level of the elbow joint, but we need to be more definite. So what's that definite point? It is at the level of the neck of the radius. Sometimes they will ask that in some multiple choice questions. So remember, this is our radius, and this is the head of radius, and then this is the neck of radius. So actually this muscle terminated at this level, and at that point of termination, it terminates by dividing into two branches. And because they are the last branches, we call them the terminal branches. So quickly, a quick recap on this. Its origin is below the level of the teres major muscle, and its termination is at the level of the neck of the radius, in the elbow joint, or more precisely, at the cubital fossa. Now, it will pass deep into the cubital fossa before dividing into these two terminal branches. Did I tell you the names of those branches? We have the radial artery laterally running here and the ulnar artery running medially. So these two terminal branches are the branches that will come off from this point of brachial artery at this level of the neck of radius. So let's make progress. We will now wrap up our lecture by looking at the branches. This gives us a very good illustration of the branches. So here we're seeing the brachial artery still coming down. But at this point, it has given off that branch I told you about, the deep branch that will run posteriorly and go to the posterior compartment. That deep branch coming off from brachial artery. So this branch is actually called the profunda brachial artery, or the deep branch of brachial artery. So this branch, you can see it here, at this point it's running behind, and it is running with one of the nerves, very important nerve. The name of that nerve is the radial nerve, and they are running along a special groove at that posterior surface of the humerus. The name of that groove is the spiral groove. There are other branches. One of those branches will be entering the humerus, supplying the bone humerus. So that branch is called the nutrient artery. There are other branches I'm interested in. I'll start from above and then we'll come down. The first branch here is the superior ulnar collateral artery. Now we have another branch called the inferior ulnar collateral artery. Now this superior ulnar collateral artery does something that I want to mention here. This branch is the branch that ran with ulnar collateral. That means they are running alongside the ulnar nerve. Ooh, ulnar nerve, where is it coming from? Ulnar nerve is one of the branches of brachial plexus. It's coming from medial cord of brachial plexus. But remember, this lecture is on brachial artery and not on the nerve. But let's make that point now. Radial ulnar collateral artery will run with ulnar artery. And remember, they first run in the anterior compartment, and towards this distal part, they will pierce the medial intermuscular septum to run posteriorly. So we've seen all the branches of brachial artery now. So what are those branches? Let's look at them again. Number one, we said the profunda brachial artery. Number two, we said the superior ulnar collateral. Number three, the inferior ulnar collateral. And don't forget those two terminal branches. On the lateral part, that is the radial artery, and on the medial part, that is the ulnar artery. Let's make progress. Clinical anatomy. How do the things we've talked about so far, how do they add up to taking good care of your patients? So that's where we're going now. And we're going to start with a number of things that happen with the humerus. Remember, the humerus is that bone of the arm region. The first thing we'll consider is some features of this humerus. This humerus has some nerves that actually run their courses very close to this bone. And because they run very close to this bone, these nerves will become liable to injuries, assuming we have fractures at these regions of the humerus. And it gives very serious clinical concern. We must look at them and look at some of the consequences if these nerves are actually injured in such fractures. Now, first, those nerves. Now we have the axillary nerve. The axillary nerve will be seen very close to the part of humerus called the surgical neck of humerus. That is this point. The next important area of humerus that has these nerves coming close to it is the spiral groove. Do you still remember the nerve? We mentioned the nerve. Yes, we did. Radial nerve. What's the name of the artery that ran close to it? Brachial artery. That's good. So at the point of the spiral groove, we see spiral groove or radial groove, we see the radial nerve. Now also we have another nerve coming very close to the bone. Now this nerve is the ulnar nerve. Remember, the ulnar nerve is here. And this nerve will run behind the medial epicondyle, and this is the representation here. So sometimes we also see fractures of the medial epicondyle giving concern, injury to this nerve. Also, you can also notice this nerve. I'm sure you're wondering, what is this nerve coming here? Since I've mentioned these three other nerves, I've not talked about this other one at the center here. So the nerve here is called the median nerve. So we also noted that some fractures that relate to this distal part of humerus can also involve the median nerve. So, but not to worry, we're going to see all of them in this part of the video, not another one. We'll also look at some common sites of fracture. We've indirectly mentioned them. The first common site of fracture of the humerus is at this point, the surgical neck. Why do we call it surgical neck? That place is a little narrow. The humerus has another neck too. For those of us that are doing anatomy major, that part is called the anatomical neck around here, but anatomical neck is not our concern now. Our concern is this narrow part of the humerus that joins the shaft to the head. That part is called the surgical neck. We also have the shaft, and this part of the shaft, particularly the radial groove, they are common sites of fracture. And finally, the epicondyles. Epicondyles or the supracondylar region. I'm going to give you more information on these points I've raised as we make progress. Now let's start with some other thing that is very important about fracture of the humerus. If we divide the humerus into three parts, we'll be seeing the proximal third, we'll be seeing the middle third, and then we'll be seeing the distal third. Look at those three regions. We can divide here. We can call this the proximal third, middle third, and then the distal third. Why am I taking pain to do this? Because there is something that is problematic in this region of the humerus. This region of the humerus, that is the junction of the upper and middle thirds, it has very poor blood supply. You see, the humerus has good supply at the proximal part, at the distal part, but very poor vascularization at this middle point I mentioned. So why am I talking about it? Because fractures at this point will show delayed union or even non-union. Now we'll look at the fractures of the humerus. Remember we talked about the surgical neck. I hope somebody remembers the surgical neck. When we have fracture there, which nerve are you expecting to suffer damage? Your right axillary nerve. Let's have a picture again. This is a fracture at the surgical neck. Here you can see the axillary nerve wrapping round the head of humerus at this part of the surgical neck. So with this fracture here, you will expect that this nerve lie very, very liable to injury. So that is what happens when we have fracture at the surgical neck. The axillary nerve lies very vulnerable. And if axillary nerve is damaged, what do you think happens? All the muscles innervated by axillary nerve will actually have problem. And we've done videos on this area of anatomy. So let's move to the next fracture. Fracture at the proximal part of the humerus or at the mid shaft. Just remember what's happening at the mid shaft? The radial groove. That's right. So this is a fracture at the radial groove, the mid shaft. That is what we're having here. And I'm sure you remember the nerve there now, the radial nerve. So the radial nerve will be affected. And of course, if radial nerve is affected, you know, oh, that means there's going to be a damage to our triceps. Yes, if triceps is affected, what happens to the action? You remember one. At least remember extension of the elbow. What extends the elbow? The triceps muscle extends the elbow. So that movement is impaired. Is that the only muscle? No. The radial nerve also supplies many more muscles down. And you're going to get the full gist of this in our lecture on the forearm. And the consequences will eventually lead to a condition called wrist drop. And that lecture will give you, actually explain step by step on how we arrive at the wrist dropping. But for now, know that for fractures at the mid shaft, the radial nerve may likely suffer damage. We will now consider supracondylar region. I hope you still remember the supracondylar region. Those regions of the humerus that are above the epicondyles. What are the epicondyles? The medial epicondyle and the lateral epicondyle. I hope somebody still remembers that. So these are our epicondyles. That's the medial epicondyle, that's the lateral epicondyle. So where's the supracondylar region? These regions are the supracondylar regions. And we have so many structures here. Many structures are there. We're seeing here, we're looking at the brachial artery, lying medial to the brachial artery. We're seeing the nerve here. What's the nerve here? That's the median nerve. If we go towards the medial part here, that's the medial epicondyle. You remember that structure that ran deep to medial epicondyle? That is the ulna. If you go laterally here, we're looking at the radial nerve. So let's see what happens here. So if the proximal fragment is displaced anteriorly and laterally, we are moving laterally. Here is laterally. Of course, you expect which nerve to be damaged? Radial nerve. Let's look at this diagram. Here, that is when this fracture at the supracondylar region is displaced anteriorly and laterally. Oh, this nerve is suffering damage. That's the radial nerve there. I'm sure you're happy you're not this patient. All right, we're going to take another picture where we're seeing a different direction of displacement of supracondylar fracture, and that is medial side. So if the fracture is displaced anteriorly and medially, what structures are you expecting there? Let's take a look at our picture again. These structures are going to be involved. Remember, we saw the median nerve, that's the median nerve here. And we also saw the brachial artery. So what structures lie vulnerable? The median nerve and the brachial artery. They can be damaged. What happens if you look at our study on the muscles of the forearm? You will see that median nerve supplied very high percentage, most of the muscles of the forearm, anterior compartment of the forearm. Median nerve did that. Of course, it did that with another nerve, the ulnar nerve. That's the anterior compartment. Make sure you pick up that video and look at it. Then there will also be inability to pronate the forearm. What is happening? We are having the pronators of the forearm in this anterior compartment, and the nerve that will be supplying them, that's the median nerve. If it's affected here, pronation is going to be a problem. And because the brachial artery can also be damaged here, we are going to have loss of pulses in the radial and ulnar arteries. Why? Because the artery that divided into both has already been damaged at this proximal part. That is what happens when we have supracondylar fracture displaced towards the median aspect. We will consider damage to the long head of biceps brachii. I hope somebody remembers where it's coming from. Here, supraglenoid tubercle and the glenoid labrum. So when this happens, what do we expect? Here, we expect the origin of this muscle, but by the time it actually ruptures from this point of origin, the muscle retracts in, as we are seeing here. So this retraction will now lead to the formation of the muscle bulk in this part of the arm. It will give rise to very unusual bulge, and this bulge is called Popeye deformity. Probably you've seen one or two persons with this kind of deformity. As soon as you're looking at that, you're sure that this man may have lost the attachment of the long head of biceps brachii. And of course, it comes with a lot of discomfort. How does this happen? It could happen following very repetitive movements, baseball players, or the tennis players, or the volleyball players. And such activities like swimming, it can also come as an occupational hazard. Most likely when we have some repetitive activities that we can notice in assembly line work, in carpentry, plumbing, and a number of other things. Also, there are other things that can come as a result of rupture of this long head of biceps brachii, apart from Popeye syndrome, because this muscle also helps to stabilize the head of the humerus. There could be superior displacement of the head of humerus. Let's also look at our picture. So here is the long head helping to stabilize the head of humerus, and of course by the time we have rupture of this long head, we can have this condition here where, following other activities, the head of humerus could be pushed superiorly, and there will be this upward migration of the head of humerus and displacement from the glenoid fossa, leading to this condition where the head of the humerus is displaced superiorly. There can be other injuries that can also affect other muscles. One of them is brachial muscle strains. How does this happen? There could be excessive force or other repetitive movements on brachialis muscle. And when this happens, it could lead to pain and limited range of motion, because some of these motions are accompanied with pain. And we know such motions as elbow flexion. I hope somebody remembers the major work of brachialis. Yes, elbow flexion. We can also have injuries to coracobrachialis, but this is less common. Where does coracobrachialis peak origin from? Tip of coracoid process. That's right. This may not be as common as others, but when it happens, it can come as a result of direct trauma or overuse of particular movement and this muscle. And then, of course, when it comes with pain, weakness of the movements associated with this muscle. Which of the movements are you thinking about now? Flexion. If biceps brachii can rupture, the tendon can rupture. Triceps can also rupture. So we also have triceps tendon rupture. This occurs when there is a sudden force or chronic degeneration of this muscle. And then when this happens, it leads to weakness and limited elbow extension. That's right. Remember the function of triceps? Extension. Wow. This is where we'll end our lecture on the arm. Probably you have questions or maybe some comments. We won't mind suggestions. Drop all of them in the comment section. We have other lectures on the hand, forearm, brachial plexus. This will give you a very wonderful and effective learning experience. So make sure you get those videos. And if you think this material is helpful, we encourage you to subscribe now if you have not. Yeah, like the video and then share it to your friends. And together we will build a unique anatomy family. What do? We make anatomy simple. I'm your tutor, Professor Anyanwu Godson Emeka. Make sure I see you in my next video. Bye.